PCOS right now has no approved drugs or therapeutics with a PCOS on this label. And I think that's a huge gap in the field, given PCOS is one of the most substantial and significant medical burden that behooves that women has. And I think that's a really substantial gap that we really want to fill at PostEra. Being first in disease means that we are able to deliver a therapeutic that is regulatorily approved and went through rigorous clinical trials. Right now, PCOS does not have a therapeutic with a clear PCOS label on it. And I think patients deserve therapeutics that went through all this regulatory process. But also, we hope that by doing so, it is a rising tide that will lift all boats and actually create an ecosystem for PCOS therapeutic development. We chose hirsutism as the initial foray to PCOS because multiple patient groups around the world has flagged that as one of the major concerns. They also flagged that although pregnancy is rightly a concern of PCOS patients, that actually so much of their quality of life is impaired by excess hair growth. Hirsutism also has a very clear clinical endpoint, the MFG score, which has been validated multiple times in clinical trials. And this endpoint is shown to be correlated already to androgen excess, which is a clear biochemical marker that we can modulate with our therapeutics. After hirsutism, we do plan to expand our indication into metabolic dysfunction, potentially other facets of PCOS as well. But we think hirsutism is a very robust and a medical need that patients want, and we believe we can deliver. AKL1C3 or aldoketo reductase, the enzyme that we are targeting, is overexpressed in PCOS patients relative to healthy women. GWAS studies also demonstrate correlation with testosterone, and that we have mechanistic pathway analysis demonstrate AKL1C3 is responsible for testosterone production. We think that this enzyme is at the root cause of androgen excess in PCOS patients. And therefore, we think that targeting this enzyme drives at the reason why androgen is excessively produced. Androgen itself is important physiological function. It's just overproduction of it and dysregulation of that driving pathological response. And so we think that broad androgen blockers, unsurprisingly, perhaps has tolerability issues, but being very precise and just looking at the root cause of excess is the way to achieve a safe and tolerated therapeutic. Mechanistically, androgen excess has been attributed by multiple scientific studies to be the root cause of metabolic dysfunction. Therefore, we think that by targeting excess testosterone, we're actually targeting the root cause of the issues. Third is that there's a world where GLP-1s and androgen modulators can be combined, given that they are operating under very different mechanisms. And we believe that having more therapeutic options for the PCOS community is a good thing for the field.